Hello, everybody. Welcome to the Research Roundtable Seminar. Thank you for joining us. Lots of new faces, new people. I see Disha from CHI. Hello. Just going to get started in a minute here. And if you can, please take a moment to introduce yourself in the chat. You should all be able to write to everyone in the webinar chat, and please just share your name, your organization, and what brought you here today. I will do the same. Hello, hello. Thank you so much for joining us. Lots of new folks in the room, in the Zoom room. Hello, Rong. So great to have you here. Couple folks from CHI, welcome. Hi, Mary. Hi, Morgan. Jessica, great to have you all. All right, I'll leave that up just for a moment here, and then we'll get started. I don't know if Dr. Renée Boynton-Jarrett, you want to take just a minute to introduce yourself before we get started?
Greetings, everyone. And if it's the first time we're connecting in 2025, happy 2025. I'm Renée Boynton-Jarrett. I have the privilege of working with our director of the GROWBABY Research Network, Claire Biglione. And I'm so excited about today's seminar led by Renée Nogales from the Burke Foundation, who is just a true champion in this space. So happy to be in community with you all today and really looking forward to this discussion.
Thank you so much. So this is our quarterly Research Roundtable Seminar series. And every few months, we invite a speaker who's kind of leading the force in the field and expanding group care, researching group care, or a practitioner or clinician to share some of their recent efforts and projects with us. And then it's an open opportunity to ask questions. So we invite you to ask questions in the chat throughout, and then we can have a discussion with Renée at the end of the seminar. So we are representing the GROWBABY Practice-Based Research Network, and we're under the Cradle Lab, which is the research and evaluation arm of Vital Village Networks. GROWBABY as an organization conducts research and evaluation across clinical sites that are interested or implementing group care. And we also kind of offer a variety of resources and toolkits for those that are interested in implementing group care. Also having collaborative spaces online for people to come together to share lessons learned and just their efforts in implementing group care on the ground. Lots to learn, lots to share. We're a collaborative community, and we invite you all to join us. And we're under the larger umbrella of Vital Village Networks, which Dr. Renée Boynton-Jarrett founded in 2010, and Vital Village focuses on expanding partnerships between residents and community organizations, started in Boston locally and has since expanded with projects across the country, really in building community advocacy and collective impact across community organizations. So for the GROWBABY Network membership, we invite you to join. It is free to join. If you do join, we have several activities you can be a part of. You can join these research seminars, but we also have kind of private project-based meetings where we talk about projects and different sorts of investigative projects we would like to do within group care. And those happen also quarterly. So we have some private meetings that you can be a part of to talk about different ways to get involved in collaborative cross-site research. So you can attend these GROWBABY research meetings and presentations, and you'll have access to different sorts of trainings and webinars through our archived presentations. And then we also share a newsletter, a quarterly newsletter where we try to kind of consolidate and share different opportunities in the field, both related to funding, publication opportunities, training opportunities, and try to make it as relevant to those that are interested in group care as possible, both prenatal and postpartum, although we focus mostly on the pediatric group care models like centering parenting. And then if you kind of join and participate, you might have the opportunity, and we would love to invite more people to participate more actively in serving in PI or investigative roles, leading projects with us, or serving on our steering committee. So here is our membership registration form from the GROWBABY Research Network. We will drop this in the chat. Free, takes just a few minutes to fill out. Thank you in advance for your time filling this out, and we will add you to our various listservs to make sure we get you the opportunities as being part of this learning community. A couple of our upcoming meetings in April, we do have a GROWBABY Research Network Steering Committee meeting on the 22nd at 4 p.m. Eastern. And then in May, we have a pilot projects meeting, which is closed to those that are current members of the research network. And we'll have a postdoc, Astrid Van Dam, from Group Care Belgium, share a little bit about expanding centering in Belgium and some of the recent work that she's doing. And we'll also give status updates on our various projects. We have some quantitative, qualitative, and electronic medical record-based projects where we're analyzing data around outcomes. And then in June, I'm really, really excited to be in have the Beloved Birth Black Centering team. Multiple members of that team from California share some of their work on their Black Centering program, which is really by Black women and for Black women. And so we'll be able to learn all about their program, and they have some really interesting research that they're conducting along with some work in advocacy. So that'll be a great seminar. Please mark your calendars, June 20th at 3 p.m. Eastern. And then July will be a bit of a pause over the summer, and then we'll reconvene in August. So those are upcoming series of events and meetings for you all. And with that, I'm so excited to have Renée Nogales here. She is the Director of Programs at the Burke Foundation, and she manages a growing portfolio of maternal and child health grants. And Renée earned a degree in English from Haverford College and holds a master's from Lyndon B. Johnson in Public Affairs at UT Austin, from UT Austin. Renée is very passionate, a strong partner in promoting health, education, and economic equity for children and families in under-resourced communities so that they can all thrive. And with that, we will pass the mic over to Renée. Thank you, with gratitude that you are here. And I can share and run your slides. So we'll just pause and I'll get that started.
Excellent. Well, good afternoon, everyone. I'm really honored to be here and so grateful to Dr. Renée Boynton-Jarrett and to Claire for inviting me to speak about centering in New Jersey. I'm Renée Nogales, Director of Programs at the Burke Foundation, and even though I can't see your faces, it's nice to have some folks who I met at the Group Care Leadership Workshop in Boston last September, and really happy that some of my colleagues from the Centering Healthcare Institute are also in the audience. So today I'm going to cover the Burke Foundation's approach to grant making, share our experience with centering in New Jersey, highlight key learnings, and discuss what's ahead. And as Claire mentioned, I encourage you to put your questions in the chat as they pop up in your head. I am not good about tracking the chat during Zoom presentations, so Claire, please interrupt at any point. I'm fine with that. So we can skip, yep. So Burke is based in Princeton with a team of 7, and we have a small but mighty board of trustees, including Dr. Boynton-Jarrett, whose expertise and support are invaluable to our work. We primarily fund in New Jersey, and last year our programs reached about 4,000 families. We issued about $4 million in grants and leveraged a similar amount in co-investment. The foundation was endowed by the late Jim Burke, former CEO of Johnson & Johnson, who became widely known for his ethical leadership. And Jim was passionate about improving children's health and well-being. And fun fact, there's a family connection to the late T. Barry Brazelton, a pioneer in the fields of pediatrics and child development. Our funder's legacy continues to inspire our work. We advance this vision by partnering with nonprofits to identify, evaluate, and scale programs and policies that help kids and families in New Jersey thrive. Jim's son, James, carries on this focus, and together with our board and executive director, Atia Weiss, they identified pregnancy through age 2 as the key window to really maximize impact for New Jersey families by pairing primary prevention with wraparound supports. And we deeply believe this period demands our attention because brain science shows it's a critical time for development. We really embrace a 2-gen approach at Burke, which shows a child's well-being is shaped by the physical and emotional well-being of the caregiver. And investing early just makes economic sense by reducing the need for costly interventions down the road. So how did Burke get there? About 7 years ago, the foundation conducted a national field scan to explore early childhood funding opportunities, and we consulted dozens of state and national experts along with community leaders to really guide our investments and serve as a resource for other funders and policymakers. And from those conversations, we assessed over 50 programs using criteria like demonstrated evidence, likelihood of being scalable, sustainable pathways, and so forth. And then we identified 4 core initiatives: centering, community doulas, Family Connects, which is a universal newborn home visiting program, and Healthy Steps. And we started all of these as pilots, and now they are in some stage of scaling in New Jersey. And we've been really fortunate that much of this work aligns with the Murphy administration's priorities and First Lady Tammy Murphy's Nurture New Jersey initiative. And this alignment has really helped us build strong relationships with state leaders and advance these 4 models while also supporting the administration's goals. So how we do our work is by piloting promising programs, scaling those that demonstrate impact, and investing at the systems level, because we all know that supporting individual programs alone won't create lasting change. And Burke's 4 focus areas are healthy pregnancies and strong beginnings. We've been really committed to improving maternal and infant health in New Jersey, where Black women are 7 times more likely to die from pregnancy-related complications than white women. And reducing these disparities requires, high-quality, relationship-based, patient-centered care, like centering. Healthy parent-child relationships, which are really critical for shaping a child's physical and emotional well-being and future success. We think that, by reducing stress on families, really supports safe, stable, and nurturing relationships, setting kids up for success. We're also deeply committed to Healthy Futures workforce that reflects the communities they serve, including community doulas, public health nurses, and family child care providers. And for this last section, policy work and systems work really, are a key for long-term sustainability. We're funding a First 1,000 Days Policy Coalition, and the first issue we're tackling is accessible, affordable, high-quality childcare. And then we will fold in other policy areas as it makes sense. And then really quickly, our team just loves this slide because it shows how our 4 core initiatives really complement each other across a continuum of supports for families. Okay, so now let's dive into centering, which is why I know you all are here today. So to start, here's a quick recap of Burke's involvement in centering. It came on our radar first during Burke's national field scan that informed our Investing Early report that I mentioned earlier. And in 2019, this led us to join the State Department of Health and 2 other private foundations to pilot 5 centering sites as part of First Lady Tammy Murphy's Nurture New Jersey initiative. It was an initiative that was launched in early 2019. It's a multi-agency effort to really help New Jersey become the safest and most equitable place to deliver and raise a baby. And it really focuses on improving equity in maternal and infant health outcomes, especially for Black and Brown women, and reducing maternal and infant mortality and morbidity. So building on the success of that pilot, we kind of planted a stake in the sand, and we partnered with Centering Healthcare Institute, or CHI, to expand by up to 50 sites in the state. I think many of you know CHI is a Boston-based nonprofit dedicated to replicating the centering group care model. They're now in 46 states and territories, and it traces its roots to a nonprofit founded by Sharon Rising, who I know many of you are familiar with. And around this time, CHI was undergoing organizational changes, and so we no longer had a full-time in-state program manager. So to maintain momentum, Burke created the New Jersey Centering Alliance with some state-based partners, and the NJAP, and a policy institute that really focuses on healthcare, to really help us build statewide capacity and establish centering as a sustainable healthcare option. And the goals of the Alliance were to expand the number of practices that wanted to adopt centering, increase reimbursement rates for pregnancy through Medicaid, and look at securing new financing models and also grow patient demand. Really wanted to build a community of practice to share best practices and embed centering as a model of care delivery, and also to develop a network of centering champions through a statewide advisory group. And then 2 years ago, we partnered with the Rutgers School of Public Health to evaluate centering pregnancy. And the evaluation is focused on defining health outcomes for centering patients, mining implementation lessons, examining the patient care experience. So considering such things as whether centering builds trust with providers and creates a sense of community. And the ultimate goal is to really demonstrate to patients, providers, and decision makers that centering delivers added value to the healthcare system. And a standout feature of this evaluation is the involvement of community researchers. These are 6 moms trained by Rutgers who really helped. They have lived experience in Newark having babies, and they helped design the focus group questions and the patient surveys. They led the focus groups and also observed group sessions. And then finally, in 2024, with the support of our board, we decided to pause expansion and dial down the New Jersey Centering Alliance to really focus on strengthening implementation. So let me, you can go on to the next slide, Claire. Let me briefly explain how we reached that decision. So by January 2024, we were about 3 years into our expansion of centering, and it felt like it was a good time to pause and take stock of our progress. And in terms of growth, we were about halfway there. We had 17 centering pregnancy sites and 6 centering parenting sites. But the pace of growth had slowed down. And this slowdown really wasn't surprising. Centering requires significant changes within a practice, and the challenges were really amplified by the COVID-19 pandemic. So first, we took a step back to identify implementation barriers and challenges. And many of these may sound familiar to those delivering group healthcare. First, inadequate staffing capacity. Some sites didn't have anyone dedicated to the centering coordinator role, and sites were often relying on a single billable provider, which really creates vulnerability during turnover or if someone goes out on FMLA. And in some sites, leadership buy-in was sometimes lacking. Second, there were operational issues, so limited space, no funding for materials, and a low enhanced Medicaid rate for centering pregnancy. It's $7 per visit per patient, which every time I say that out loud, it's unbelievable. And there's no enhanced rate for centering parenting. And then third, there were some service delivery challenges. Groups sometimes fell short of the ideal size, which is 8 to 12 pregnant women or 6 to 8 families, depending on the model. Some sites were really facing significant delays in launching, or they were having to pause and restart groups. And many of these challenges were also surfaced in the centering pregnancy evaluation. So it was helpful to get some validation of what we were hearing from the field anecdotally. So given these challenges, we decided to conduct a site analysis to assess implementation. We focused on identifying key ingredients for successful centering delivery based on best practices from CHI. So first, patient recruitment and demand. If you start a centering site, will the patients actually show up? Will they want to get centering? Sites ideally offer more than one group. This really helps with sustainability by increasing patient volume, and then you can make the financial case to the folks that make those decisions at the healthcare practice. Staff capacity. Is there more than one billable provider? Is there a designated centering coordinator who can really take on some of the supportive tasks to help the team be really strong and have them focus on the care delivery? Is there leadership buy-in? Are there other innovative care models? So, this isn't necessarily essential for success, but it's a good signal of site readiness. So, for example, if a site is delivering Healthy Steps, which some may know, it's a team-based pediatric care model that adds a child development expert to the care team, those sites may be more open to trying new care models. And so we gathered data from various sources through monthly check-ins with CHI to our own site engagement, reviewing accreditation reports. We analyzed all 23 sites and kind of grouped them into 3 categories. So you've got the strong implementers. These are the sites that we thought really had most or all of the key ingredients. For example, there's one site that uses an opt-out policy, meaning that low-risk prenatal patients, they get assigned a midwife automatically, and they get centering pregnancy. They've got groups starting every month, and I actually heard recently that they have a wait list for their Spanish-speaking groups, which is fantastic. On Track needs more support. These are sites that show promise but face challenges. For example, there's one site that's led by a committed physician. There's strong patient demand. But if you just have one provider, that really constrains patient volume and financial viability. And again, if this person has to go out on leave, then the program will really grind to a halt. And then the at-risk group, these were sites that were facing pretty serious challenges. Luckily, there weren't that many of them. There was one FQHC that I think the CEO told me that they lost all of their clinical staff, and they just had to really focus on other things, understandably. There was another site that struggled with enrollment. They just couldn't, from the very beginning, they just couldn't get it off the ground. And then a third site lost its license to practice, not license to practice entering, but just license period. And I think I'll talk about lessons later, but I think one specific lesson learned in this category is that I think for us, we learned that we really need to be very cautious about partnering with really small private practices, and to do more thorough vetting is needed. So after reviewing, you can go to the next slide, Claire, thanks. So after reviewing the data, having internal discussions, meeting with our board, we developed 3 key recommendations. So number 1, we did want to pause expansion to focus on quality implementation through 2024 and also into 2025. Couple kind of key things that happened in this bucket. We were thrilled to learn that CHI was kind of with us in this journey, and they hired a state-based advisor. to focus exclusively on New Jersey, which was the case in the pilot. So really pleased to see that, and Kelly's fantastic. And then Burke plans to provide grants to select sites to address operational challenges, really strengthen those key ingredients, and build a more solid foundation. Burke and CHI developed a process to identify grant recipients. First sites had to fill out needs assessments. There was a whole slew of site visits. I had the privilege to join a small number of them, but CHI led them, I think at least a dozen. Those have been wrapped up, and now sites are going to be submitting action plans. So really concrete plans on taking some of the operational challenges that really are serving as a barrier to long-term sustainability, and really mapping out how they are going to use that grant funding to support them in that effort. And those, I believe, are due next week. So I know CHI is excited to get that. And as I understand it, they really enjoy this framework, and they plan to also apply this process to their other 4 priority states. New Jersey is one of 5 under its new 3-year strategic plan. Number 2, we want to advance financial sustainability efforts. So with this effort is really led by our partner, the New Jersey Healthcare Quality Institute, really to make the case to New Jersey Family Care, which is our Medicaid program, to increase that rate. I mentioned it's $7 per visit, and we would love to see them consider a similar rate for centering parenting. Some of you may know other states typically offer between $30 and $50 per visit. And we also want to explore making FQHCs eligible for the enhanced rate, which they cannot do in New Jersey, but I know that CHI has figured out how to make it work in a handful of other states, so we would love to see that happen here. And we'd also, we've kind of kicked around the idea of a pilot with one of the health plans. We'd love to explore a bundled value-based payment for centering. I know CHI has developed a really nice framework for that. And we know that in another state, there's a health plan that pays kind of a set amount to sites each year to cover some of those expenses like, patient notebooks and so forth. Now, everyone knows, I think, the elephant in the room, or maybe it's not really an elephant, but everyone knows that anything right now having to do with Medicaid is going to become more challenging. So there are bigger issues at play, but I think we're going to, keep pushing forward and see what we can do. And then number 3, really refocus future expansion on 1 to 2 health systems instead of kind of a site-by-site organic approach to program development. So our partner is going to be conducting a readiness assessment of health systems to help identify those that may be more receptive to adopting centering. And the goal is to really build those relationships with those that are well positioned to implement centering, and ideally some other of the first 1,000 days initiatives like Healthy Steps. So we would love to go to a health system and almost like pitch the idea of a baby bundle with some of these different models, really get strong leadership buy-in, and then incentivize them to make a multi-site commitment. And I know that that aligns with what CHI is thinking in terms of its 3-year strategic plan. So this is where we are now, and I want to share some of the key lessons we've learned so far. So first, early implementation is really critical. It's the first 3 years. Some could probably argue it's the first 4 or 5 years. I think that, you all can appreciate that delivering an evidence-based model does not guarantee positive outcomes. High quality implementation really depends on fidelity, which requires ongoing CQI, coaching, monitoring fidelity, and also doing regular reviews of data. Lesson 2, so nurture staff capacity at multiple levels. A centering site is not going to survive long term if it relies on just one or even two champions. Lesson 3, I think one thing we've learned in working with sites in New Jersey is to help do that, one strategy is to really think about leveraging other staff to strengthen centering implementation. A few sites in New Jersey are using Healthy Steps specialists as co-facilitators, and one site has started to use their hospital-based doulas as co-facilitators as well. Lesson 4, I described this earlier, but we see really adopting an opt-out enrollment approach where centering is really seen as the standard for pre-care. It's not just the shiny new thing. It's really the way that a practice is committed to delivering healthcare, and that it's just more likely to stick long term. Lesson 5, the centering pregnancy evaluation showed that both providers and patients value centering, like full stop. Patients reported they enjoyed learning from each other and healthcare providers. They really appreciated the extended, meaningful conversations that made them feel empowered. Really loved the group camaraderie and sense of community. They reported having reduced feelings of isolation and loneliness, which was wonderful to hear. And interestingly, the evaluation team talked separately to the providers about what they saw as the value that patients got out of centering, and they reported these same benefits. And then the providers also reported that they were better able to identify and respond to patients' needs. You just spend so much more time with your patients. You're able to have those, rich conversations, and just a lot of other issues bubble up that the providers can address. They reported having a greater satisfaction in their jobs, and they also felt that it reduced burnout. And then in terms of, some of the challenges, and I think some of the patient challenges from the evaluation are accessible, and I think some, like transportation, that's more of a systemic issue that's not, it's not specific to centering, right? So some of the challenges that the providers mentioned, I think the top one was staff turnover. And this is a problem, as you all know, healthcare writ large. And also the lack of dedicated time to really be able to focus on centering, like having someone to serve in that coordinator role. Lack of space for group sessions. Some spaces are really too small to optimize the group size or even expand. We heard from sites that said, I would love to offer multiple groups, offer on different dates, but the space just wasn't allowing for that. Although some sites are getting incredibly creative about using things like their waiting rooms, either before or after office hours. And then the providers, again, mentioned the low enhanced Medicaid rates. There's nothing in the budget or nothing in the general ops budget for things like, snacks or materials after grant funding ends. And I think some sites, would pursue donations or even have it in the past. But I think, as we all know in this day and age, nonprofits are becoming even more vulnerable. I think more people are going to be looking for donations. So that's going to be tough going forward. And then some of the challenges that patients mentioned, some described how they really want to describe private matters in a separate room. And doing health assessments in the same room is really part of the model. I think there are some sites that have figured out a way around this. They use white noise machines, offering private time after the group and just making that super clear to the patients that that is available to them. Heard that, some of the information for moms who had already had babies, it was a little repetitious, but they actually had the idea if the volume would make sense to have a separate group for just first-time moms, which I know some sites in the country do that. This is the continuity of care. This is kind of one of those things where you're not going to please everyone, right? So some patients really prefer to see one provider the entire time. I think many of us see the great value in a continuity of care. Others wanted exposure to multiple providers in case, they went to deliver and their provider wasn't there. And I think, this is something that could be addressed by, having like providers rotate in as guest speakers for certain topics. I think that's a great way to allow the group to get exposure to the rest of the care team. Wait time, we heard this from some patients, wait time during one-to-one health assessments. For me, I think some patients were describing that there wasn't a lot happening while those health assessments were happening one-on-one. And, for me, I think this just signals a newer site that needs more experience with facilitation. In general, my impression is that there isn't a lot of downtime in centering groups. There's a lot of activity, a lot of conversation. So I think that's just a symptom of a newer site. This is tricky. Another one of the issues that were surfaced was having siblings present. And this is tough. You want to balance the need to accommodate parents with kids and who have childcare issues, but you also want to maintain a focus group environment where, the conversation can be rich and the patients can really pay attention and focus. And that's sometimes hard when you have little kiddos running around. And then I think probably the one other thing that some of the patients raised is, there was no option for it to keep going in the pediatric space, which obviously is something that could be addressed if we can expand centering parenting, which we will get back to doing in New Jersey. Okay, so what's next? And then yep. So in 2025, I already mentioned, our big focus now in partnership with CHI is to really implement the site support phase. All of the site visits are done. The sites are working on their action plans. And then once the funding is given out, CHI will be in a position to, monitor progress, provide extra TA as needed. We are going to be finishing the evaluation and getting the findings out there. Probably the first place that is going to happen is Burke is co-sponsoring a first 1,000 Day Summit in May with the New Jersey chapter of the American Academy of Pediatrics. We are thrilled to have Dr. Boynton-Jarrett co-moderate the summit. And the goals are really to focus on strengthening New Jersey's commitment to making the state the safest, most equitable place to have and raise a baby. Really going to highlight the importance of those first 1,000 days, promote relationship-centered care through evidence-based innovations, and really celebrate all the great work of the state leaders over the past 7 years to really drive progress in maternal and infant health. And one of the workshops at the summit is the Rutgers. They're going to present the findings with a couple of the community researchers, which is really cool. And then kind of the second half of the session is, CHI is going to facilitate some like live workshopping on some of the issues that were surfaced in the evaluation to try to figure out like how to problem solve with their peers. The other thing that we're going to be focused on is we're going to be partnering with CHI on, this is probably a little bit later in the year, but thinking about growth and sustainability as one of the priority states that CHI picked as part of its 3-year strategic plan, courtesy of an investment by Blue Meridian Partners. And we really want to remain focused on financial sustainability. I mentioned the ways that we're going to try to do that. We're going to look at some cool things that other states have been doing. But these are really tough times. And I think everyone knows that we really don't know what's coming down the pike or the fallout from the administration that's in DC right now. I think one thing we do know in our sense is that, given the current climate, I think anything that we can do to elevate return on investment for, centering or really any of the programs that we care about is going to be really critical. Okay, so I am now happy, to answer any questions. I'm really curious about what our experiences in New Jersey have sparked for you. Did anything surprise you? Have you found any successful strategies that we could like borrow? Would love to learn from the wisdom of this group, and also really grateful that there's so many people from CHI on the call, and would also invite you to participate as well.
Wow, thank you so much, Renee. I mean, I have several questions, but we've also received several questions in the chat. This was phenomenal. The work that you're doing in New Jersey is just so exciting. And you've made an incredible progress in implementation across several sites. So lots to learn from you today. Dr. Boynton Jarrett, did you want to ask any questions or make any comments as we start the discussion?
Thank you, Renee, for this incredibly thoughtful and candid presentation that I think, as you can see from the chat, many people resonate with the journey that Burke has taken and also really inspired by the scale and scope of this really ambitious effort. So I see that there are some really great comments in the chat, so definitely want to pause to allow some of those to go first, but I have a question or two I'd love to sneak in at the end.
And we can also unmute you if you'd like to share sort of in real time, off mute, some questions or comments or stories you'd like to share from your own experiences. So let's go to the top and we'll start with some of the first questions received. So from Daisy, are there any foundations, Renee, that you know of like Burke in Illinois that might fund and
Oh,
support
gosh.
centering, doulas, maternal child health? That is from Daisy.
That's a great question. The only foundation I'm really familiar with in Illinois is the Pritzker Children's Initiative. They have funded CHI in the past at a national level. I actually don't know if, and maybe CHI would also be able to answer this, but I don't know if they've ever funded at the local level in Illinois. And I don't know if anyone from CHI is familiar with any foundations operating in that state as well. I know, thank you, Mary. I know she said this before. She said, I wish every state had a Burke Foundation. That's very sweet.
Okay, that's wonderful. And if you'd like, if from CHI, if you have any comments, feel free to drop them in the chat and or we can unmute you. All right. Octavia shared that this is all so familiar from across the pond. She mentioned that in the UK, spaces are really hard to find. We've used family centers, libraries, churches, mosques, and are now looking at sports centers, shopping centers, and art galleries. Octavia, I don't know if you want to share more. I can actually allow you to speak now if you'd like to share verbally anything about sort of your UK experiences, which are so fascinating for us in the US.
I would just say that it's extraordinary how familiar all this is. And it's been really fascinating hearing about it and having a much more organized approach. I was interested to know where you get this grant money from to give to sites, because we don't have anything like that here.
Yeah, I mean, so we're a private family foundation. So this is just our, endowment. So that is, I think you were referencing maybe the grants for the sites to focus on site implementation support. So that is just from our endowment. And we always try to, when we can, and I mentioned this was the case during the 5-site pilot, we always look for co-funding. So we have some strong foundation partners in New Jersey whenever we can. I know it's sometimes tricky to do, but we've had some success doing it. We also try to partner with the state. And so obviously, whenever you can do that, you could make your dollars stretch further. And I know that we're going to be looking for, co-funding for New Jersey moving forward. And I know I don't want to speak for CHI, but I think as part of their work through their 3-year strategic plan and focusing on those 5 priority states, I think they'll also be looking for funding opportunities as well.
Thank you, Renee. From Rumana, hi, Renee. Thanks a lot for a very enlightening talk. Could you please expand a bit on the second lesson learned? So I don't know if Renee, you can go back to that slide. I can also try.
Yeah, I think it has to do with staff capacity,
Yes.
right?
Mhm.
I also would love for CHI to jump in here too. I mean, I feel like there's, some sites have really figured out how to do this, meaning centering, to do it well in terms of really building that capacity up. I think, in a perfect world, you do want to have multiple billable providers. You want to have multiple co-facilitators, because then you could just be more nimble when things are going to happen, and they will happen with your staffing levels. There's going to be people who quit. There's going to be people who move. There's going to be people who get sick and have to leave. So when that happens, your centering model will be able to weather the storm a little easier if you have multiple providers. I mean, we've definitely had a few sites where if there was a single physician provider, if that person had a baby, if that person had to leave for medical reasons, the centering had to stop there. And if that wasn't the case, if you had a team of providers, then you might need to rejuggle and reassign some patients, but you could make it work and still carry it forward. I think the other thing is that leadership buy-in is really important. This isn't new. It's not unique to centering. It's going to happen with any initiative that you're doing, but having the support of the leadership is just critical. We were at a site visit with a couple CHI colleagues a couple weeks ago. This was an FQHC. They're definitely having, typical challenges that you have when you're getting centering off the ground. But the CEO of the FQHC was, she participated in the site visit. And she said, look, we really believe in this. We're having challenges with ABC, but, this isn't going anywhere. We are committed to this long term. If her staff needed something, she would make it happen. So when you have someone like that at the higher level who has the ability to make those decisions, make things happen, you're in a much better position for implementation than if you were, just a small team trying to figure it out and you had a leader who was, they had a billion other priorities and this just wasn't one that they were going to focus on. I hope that helped.
Absolutely, Renée.
And again, if
I
anyone
hope,
from
can you
CHI
hear
wants to
me?
jump in, please. Yes, yes.
Yeah, excellent. Thank you very much, Renée. That's very reassuring, I would say, because we are just about to begin in a feasibility study. And our project's name is also My First 1,000 Days. And I was just thinking about the challenges that you are facing. And it's very reassuring to learn that about the staff capacity, we have already decided that we are going to have a team, because it would always be the case that somebody is ill, somebody has an issue or something like that. So one or the other, it's the best way to have to have a team. And what you just mentioned actually reinforces that. So thank you very much. And of course, the leadership, I would really attest to that. I think it was a wonderful thing to have a leader like that who would get into the site, speak to people, be hands-on. I think that's really helpful. And thank you very much for that.
Of course, you're welcome. And I think, Claire, were you going to let Mary
Yeah,
speak?
Mary, you're able to unmute now, so please chime in. And thank you, Ramona, for that great question.
Sure, I just wanted to jump in and again, of course, thank you, Renee, for everything you do and are saying today to support group care for pediatrics. I think that one of the things that comes to mind, though, in terms of this question for me, and I encourage anyone else at CHI who would love to weigh in on this, is well, two words come to mind: perception and integration. And it's one thing to implement a model and call it a program and get it going and keep it going. And in a program, things can be canceled. People can be, it doesn't necessarily sustain itself as a program. But when you integrate something into the system and it's part of how care is provided, it doesn't have that same level of ability to fail, right? If you were to look at a practice right now and they were to lose staff, they would still somehow manage to make their clinic run. And so looking at it from that perspective, there's a level of buy-in and a level of thought that needs to go in that I think a lot of practices don't recognize right away. And it's something that I think that we need to continue to work with sites to try to do. Yeah, I mean, I think it's a big challenge, in terms of the challenges that are facing the sites right now related to the current climate.
And Kelly, I'll just jump in. Kelly Kimbo, who is our New Jersey implementation advisor. Hi, Kelly. She did note, thank you for raising this point, that some staff at centering sites have protected and dedicated time to centering and others do not. And just to offer a very specific example, you've got the time for actually doing the session, but then you've also got the prep time. And I remember being on another site visit, this was a while ago, and the head of midwifery said, yeah, we just marked it into the schedule. Like they literally have that as part of their clinical workflow and part of their day so that they know that, I don't know if it's 15 minutes or whatever it is, like maybe it's a little longer for prep time and also debrief afterwards. So having that time kind of built in, as Mary said, like into the way that they do care is really important.
Thank you so, so much. I think this is just so relevant to everybody experiencing and implementing any program, let alone centering. Quickly, Renee, can you share a little bit more about the May conference, if that's available for people to register for? Is that more of a closed opportunity?
No, it's not. So I'm happy to, Claire, I'll send the information to you as a follow-up, and you can distribute it out to the group afterwards. Does that work?
Perfect. Wonderful.
Yep. Oh, and I'll just mention the dates. Probably having the dates would be helpful. So it's in Long Branch, New Jersey, and it's going to run May 6th to 7th. On the first day, I think we're going to start around 2 or 3 o'clock, and then the next day is a full day.
Okay, wonderful. Wonderful. I look forward to sharing that with you all. If you're here, you'll receive more information about the May conference that Renee is discussing. Octavia mentioned the needs assessment for sites sounded very, very useful. Could you share a little bit more about what the needs assessment entailed or what that process looked like?
Yeah, and I also invite folks from CHI to jump in too, but this was kind of this was phase 1 in terms of figuring out which kind of a subset of sites that we were going to really work with on this, really focusing on site implementation. And it was really just to kind of get a lay of the land. Some of it was basic information, what kind of practice do you operate? Is it like a hospital-based clinic? Is it an FQHC? Is it a birth center? What is your patient population on an annual basis? And then of that, what number are eligible for centering? How many patients are you seeing? How many patients are you seeing every year? What language needs, what languages do you actually deliver centering in? Are there, do you use certain materials from CHI? Do you have a need for more materials with, marketing? And then there were other questions about, like goals and like what's working well, what challenges do you have? And I think that was kind of a first pass at letting CHI get a better understanding of where sites were at this point in time. And it really helped them kind of prepare and frame those in-person site visits where they were able to go a little deeper and really explore some of the issues that were surfaced in the needs assessment. And I think it also really, the site visits also really allowed the staff to think very concretely about, because we really want this to be about sustainability. We don't want them to just get funding and then have the same problem a year or two from now. About how this can really resource them to become more sustainable going forward. And again, I know we're short on time, but if you want to let anyone speak from CHI, Claire, please.
Yes, if anybody from CHI also wants to chime in, please just drop a note and or raise your hand and use the raise hand function. Brian McCarroll, hello and thank you again. I work with teen and tot programs in a specialty pediatric practice. And as someone very new and excited about centering, have you had experience with youth and teen centering programs? Would love to work together in the future to help research how to best serve this specific demographic. And then experience the COVID cool down with centering as well. And Brian, if you'd like to come off mute to add more context, feel free. We have a few minutes left. Renee, I don't know if you have experience with teen and tot style programs.
The specific teen specific is not popping into my head right now in New Jersey. I think there are some conversations that sites are thinking about it. I know that they've done teen sites in other parts of the US. So if Mary or Deanna wants to jump in.
We also, I don't know, Brian, if you're a part of Boston Medical Center, but there's a teen and tot program that's running there as well, and they're kind of kickstarting centering, kind of relaunching centering, and so it would be great to partner with them if you haven't already. So feel free to reach out to me, and I can connect you. Oh, that's okay. Gotcha. And then Chiquita, I think you raised your hand if you also want to share.
Hi, Shakita with CHI. I was just going to answer the question about the teen program. There is one that I'm aware of in Texas, but I don't have the name of the site with me. Sorry, I'm traveling. So if they need more information, you can get them in contact with us and I can get the information and share it.
Wonderful. Happy to connect you to Chiquita Break then, Brian. Maybe our last question from Jaisha. There's just so many comments, so much gratitude in the chat for you, Renee, today. Thank you, thank you, thank you again. I think we could continue this conversation much longer. From Jaisha, are your materials for scoring site implementation characteristics shareable? We're doing a lot of advocacy right now around QI and would love to share that framework with our leaders if possible.
Yeah, if you're talking about the kind of the assessment that Burke did, I'm happy to share it with you. It is not a reliable tool. It was definitely part art, part science. But I'm happy to share what we did.
Amazing.
Yeah, and I can share that with you, Claire, and you could pass it along.
Wonderful, wonderful. So there's a couple things to follow up. I'm going to share my email in the chat. If you have specific questions or would like specific connections with Renee, I'm happy to facilitate those. Such a wonderful presentation. Thank you so much for your time today. What a joy to have you. Maybe we can have you back to follow up on some of the progress and lessons learned in future seminars, perhaps next year or the year after. So thank you so much.
Yeah, sure. As long as CHI joins me. So
wonderful.
Yeah, thank you so much, everyone. It was really a pleasure to be here.
Thank you. Take care, everybody.
Bye-bye.